All righty, good evening, everyone. My name is Ken Ellington, orthopedic surgeon in Charlotte, North Carolina, and I'll be kicking off the webinar tonight. I can't do this alone. I have two esteemed colleagues and friends, Dr. Terry Philbin, likewise orthopedic surgeon in Ohio, and Dr. Josh Hunter in Utah, and they'll be helping and have some portions of the talk they're going to go over in some of their own individual cases and commentary, and then we'll take questions and answers at the end of the webinar. So I encourage the attendees to type into the chat box any questions you have. Feel free to do that during the webinar, it's totally fine. And what we'll do is we'll collect those, and at the end of the webinar, hopefully just take about maybe 45 minutes or so, we will then go through the questions and answer them to the best we can. So again, my friends here, Philman and Hunter, will be sharing in the webinar as well, and I appreciate their time and commitment to helping put this on, along with Dr. Kat Smith, who works lead engineer with MedShape down in Atlanta. Couldn't do this without her and her team. So I guess one of the questions to think about is, do we really have a clinically unmet need? And we all do subtalar fusions, do quite a few. Obviously, there's many indications to perform this procedure. But the question is there a problem with what we do now? And I've been in practice for 10 years, and I know Terry's maybe a couple more longer than me, has more experience, but anyone who's done this long enough has seen the current deficiencies for subtalar arthrodesis procedures and medial column arthrodesis procedures. Notably, the subtalar joint tends to have a higher non-union rate than I think the book answer is. I think when I was in fellowship and starting practice, I thought it was like a 95% success fusion rate, and that's just not very accurate. And so there's all kinds of ways of placing hardware in or across the subtalar joint, and likewise the medial column. And some of these things have been around for decades, and some of the things that are out there are relatively new. I think that highlights that there is a unmet need due to the explosion of new devices in the market in the last couple of years, because surgeons have been able to identify and appreciate that we need something better than just one or two cannulated screws going across the subtalar joint, and other types of fixations for the medial column, whether it's intramedullary or traditional big old plates and screws with cont, which comes with its own concerns, such as soft tissue, postoperative wound infections, and dehiscence, and these challenging, typically the diabetic and neuropathic patients. So what does the literature say? And so looking at several articles, it does show that the non-union rate is maybe not as low as we think, and that union is negatively influenced by comorbidities such as diabetes and tobacco. And Easily did a great paper looking at this, like at different biomechanical comparisons of 2 and 3 screw fixation. And even with the second generation new headless compression screws and a different variety of constructs, trying to get the most biomechanical stability we could across the subtalar joint, they still demonstrated a higher non-union rate in patients, specifically those who smoke and have diabetes. And then also there's been looked at, how many screws are necessary for subtalar fusions. And the rate of non-union varies among all the authors, anywhere from 0 to 46%. So that obviously is pretty alarming. And those patients that have a history of alcoholism, diabetes, other psychiatric diseases, et cetera, and we all know that these types of patients can be difficult to work with, have higher non-union rates. And then, unfortunately, patients who've had previous ankle arthrodesis and have a solid ankle fusion, those patients may go on to have ipsilateral subtalar arthritis after their ankle fusion, mainly due to probably the wear and tear that goes across the subtalar joint after the ankle fusion procedure. And then these patients then end up developing subtalar arthritis and need a subtalar fusion. Now, trying to perform a successful subtalar fusion under a previous ankle arthrodesis, the union rate skyrockets. You can see here in this study by Easley again and his colleagues at Duke that the fusion rate was only 61%. And obviously these are talented surgeons. They know what they're doing. They knew going into these procedures, the non-union rate was high. And even with that understanding and approaching it differently and probably adding biology and doing things differently and adding fixation, they still had a 40% non-union rate. And again, getting that subtalar joint to fuse under an ankle fusion is technically very, very challenging. Likewise, there's been studies looking at the medial column. And so this paper showed that not to pick on a particular company, but this medial column Synthes midfoot fusion bolt had unacceptable rates of failure and corrective arthrodesis procedures in patients with collapsed Charcot deformity. So again, now this is definitely a challenging patient cohort, but the non-union rates were quite high with this type of fixation device. And there's, multiple studies have gone through and looked at this, and you can see here that we have all kinds of, different types of Charcot deformity, and the mechanism of failure is listed here in this paper with this Synthes fusion bolt. And migration was a very common constant theme that we saw in this patient cohort. And so these types of intramedullary fixation devices don't have any interlocking mechanism, so migration of the device and pull out is quite weak.
All right, so my name is Josh Hunter, one of the orthopedic surgeons out here in Utah. Appreciate being with you guys tonight. Let's talk about a little bit about the science behind the sustained compression, why it's important. Maybe try to not use my mouse. So sustained compression is a critical aspect of any type of fusion process and procedure. We're all trying to gain compression across any joint, whether it's a subtalar joint, ankle joint, or otherwise. It's critically important that we get some form of compression across that. Now, we get a lot of that at the time of surgery, but anything outside of the surgery is where the dynamic aspect of things really comes into play. And so in this, go back one slide. So in this slide, we can see with any type of resorption, which we almost always see with any type of fusion, anything greater than 1 millimeter, we're really getting hamstrung by the constraints of a static nail. And anything more than 1 millimeter, we're not going to see that sustained type of compressive force. And it's not uncommon or uncustomary to find more than 1 to 2 millimeters of resorption at the time of an arthrodesis. Compare that with the DynaNail, which is the precursor to the mini DynaNail that we're going to talk about a little bit more tonight. There's sustained compression with even upwards of 6 millimeters of compression. With 6 millimeters of resorption, and that's because of the compressive dynamic forces of the Nitinol filament that is found within the DynaNail. That's able to counteract and still obtain some type of compression despite having any type of amount of resorption. Additionally, with any type of nail, we always think of nails as being load sharing devices. But if there's not a compressible or a compressive force through that, then we're not really seeing that same type of distributed forces. As a matter of fact, we're actually seeing more of a stress shielding, which is exactly what we're trying to avoid, because we want our bones to share the loads with these implants so that they can still see that sustained compression. They can still see the dynamic need, the biologic need to have that fusion. So when you look at this, is a study that was done that looked at the biomechanical properties of the DynaNail, comparing it with a static nail, and you can see that the shielding was actually much higher in the static nail than it was with the DynaNail. And then again, in this paper, we can see that the transfer of the load weight bearing is actually much higher in the tibia with the DynaNail as opposed to even a titanium which has the same type of modular elasticity as the native bone with a static lock nail. So again, lots of different features that are pointing to compression and sharing that load with the bone as opposed to just with the implants in and of themselves. So this, I want to get a little bit into why I find the DynaNail so fascinating and what it really helped to perk my interest with this type of implant. All right, so this is a patient that was sent to me a couple years ago that had a terrible open fracture, seen at a level 1 trauma center, treated with multiple washouts and debridements because it ultimately became infected, was treated with IV antibiotics, and ultimately the primary surgeon told her, look, I've got no other options. All I can offer you now is a BKA. These are her initial x-rays that she presented with at the time of her injury at the outside facility. So she has a bad fracture with a bad injury. Compound that with the fact that she's diabetic. Even though she's pretty well controlled, she's still a poor host with poor healing potential. Now she shows up to me a year after this with an X-Fix on, with a draining sinus, with that she's been seeing in the wound care clinic now for the last year or so. And all she says is, I want to save my leg. Can you do anything to save my leg? I'm like, well, I've got an implant that I'm willing to try, but if this doesn't work, this is our last ditch effort, and we're probably looking at a BKA. And she said, I'll do whatever you take. I'll do whatever you recommend. Let's just try and save it. So step one was to take her to the OR. This is the initial x-rays. So you can see that she has this metal implanted with some K-wires, as well as some screws across the metaphyseal, diaphyseal flare of the tibia with some antibiotic cement. All of it's non-united. She's got a non-union of a fibula, non-union of a pilon fracture. And then she's already got some disuse osteopenia because she's been non-weight bearing for over a year. So take her to the OR. First step is just to get all the hardware out, keep her on the antibiotics, get cultures. Surprisingly, all the cultures came back negative. And so we kept her on broad spectrum antibiotics though for that first 6 weeks, and then brought her back for the next step of fixation, which was the DynaNail. And so you can see here with the slot here, this is the window that you can see where there's going to be some compression down the road that we're going to try to obtain. So intraoperatively, you can get as much compression as you can get, just like you would with any other type of nail. You get that manual compression, and then you let the Nitinol filament take over the rest for you down the road. Here she is again. Wait for it. So at time of surgery, again, bone grafts, biologics, and the DynaNail. And you can see here's going to be that little window where we're going to obtain some compression. So fast forward now 6 months out from surgery, weight-bearing x-rays. Come on. Weight-bearing x-rays show she's got solid fusion, and you can see how much compression she was able to get. And again, I put as much compression there manually at the time of surgery that I could get in there, and she still got some resorption or some compression through the Nitinol filament that allowed her to get sustained compression and allowed her to have subtalar fusion as well as ankle fusion, as well as fusion through her tibia. So she comes and sees me every year in July on the anniversary of her surgery, and gives me a little dress from my youngest daughter as a way of saying thank you for saving her leg, and she's as happy as can be as a result of this implant.
Well, that's a great save there, that's for sure.
Man, that's tough.
All right, there we go. That seems to be working. All right, so again, that was an incredible save. I think that, it's kind of the aha moment or the aha surgery like that when you see such a complex case that, one of the other options is a BKA. And then, you can really see the difference that this system has. I think that coupled with all the research, a lot that we've already talked about, was kind of a no-brainer when it came to subtalar fusions and medial column fusions. I definitely wanted to try the Mini as soon as it was available. And again, the big thing here is the active compression that you get from the Nitinol filament itself. All right, let's see if I can actually forward here. There we go. So how does it work? So basically, it's a recoverable pseudoelastic properties of the Nitinol element that enables it to maintain the compression across the joint, not just in surgery, but even when you leave surgery, you're still getting that compression. and the element will then instantaneously recover in its original length with any unloading that you have that occurs with bone healing, with bone settling or resorption. And you can see that on the stress strain gauge here on the right. So other features of the nail, for the Mini, the nice thing about the disposable guide is that it's already in, the element's already in its stretch position. So you don't have to stretch it out on the OR. And then the nail guide here is actually what we'll insert into the target frame. We already ran over how it works. We went over some of the features here. Here's basically the assembly. The elements actually housed in the titanium outer body. On both ends, it does have locked fixation with headless transverse screws. For the Subtalar Mini, it comes in 7mm diameter, and the lengths are 60 to 100 millimeters in length. And then for the medial column Mini, it's 110 to 140. And then you can use the end cap distally, which will also give you some locking features. As far as the frame, one of the nice things about the frame is it's radiolucent, so it's really optimal in getting good visualization. And because of the rigid carbon peak, it really helps with you getting excellent targeting with the system. And then you can see on the right-hand side, you can see the gold wheel that's going to help you achieve good manual compression in the operative theater. If we look here and look at traditional subtalar bone screws, you know, one of the issues is that it's static, rigid internal fixation. So what you get in the OR is what you get. And so it's not going to be able to maintain its compression in the face of resorption, which will lead to loosening of the screws, breaking of the screws, and sometimes insufficient healing. So we know that the Mini is the only internal device that will, in subtalar and midfoot fusions, that's going to maintain compression when we're getting resorption and we're getting settling. And if you look at on the side, the little chart there, you can see as the nail length increases, so will the amount of compression that we can achieve. So, you know, I've had a lot of surgeons say that, you know, they're used to doing 2 or 3 screws, and that's kind of what they do. And that used to be how I always did my subtalar fusions. You know, the thought that you're getting compression and maybe getting some rotational control. So, you know, it was kind of a leap for some to think about going to just, you know, having one point of fixation. But I think the big reason is that, you know, this is superior fixation. By just using the screws, once again, they're gonna migrate. They're gonna potentially come prominent because over time they're gonna lose fixation potentially in many cases. Whereas you're gonna get superior fixation with the Mini. And I can say anecdotally, going from in the past doing 2 or 3 screws, and now going to this anecdotally, it's worked out very well. And you can see here, again, comparing it to several alternate screw configurations, you can see that the Mini has superior pull-out resistance and stability across the subtalar joint. You can see here on this performance summary. All right, so let's get to a couple of cases. Unfortunately, because I was going forward too quickly, you guys already saw some of this. But so first case, 81-year-old, hindfoot pain and deformity. You can see they've already had some forefoot work done previously. And basically failed bracing and other conservative measures. And basically what they had is a malunion of the talonavicular joint and the CC joint. And if you look here, you can see even on a weight-bearing CAT scan how much tilt there is in the ankle because of how much deformity that they have in their hindfoot. So what we basically did was a revision triple. We included the subtalar joint and we did a talar osteotomy to swing the foot back over. And you can even see at 6 weeks the abundance of healing that we already have in all 3 joints of the triple. And then you can see weight-bearing x-ray of the ankle. You can see we corrected the majority of what was occurring in the ankle itself. And then you can see at 11 weeks here, we have the weight-bearing CAT scan. You can see the lateral projection, great healing of the subtalar joint. And even though this x-ray doesn't depict it real well, had great healing at the talonavicular as well as the CC joint. All right, case number 2, 55-year-old female, history of diabetic neuropathy, has some obvious Charcot going on here and has failed some other care, including bracing, has already developed an ulcer where the cuboid is in one time, and you can see has had other complications from diabetic neuropathy in that they had part of their great toe already amputated. So basically in surgery, what we ended up doing is more or less a triple as well as a medial column nail here, and tried to get the Miri's angle back, and then created kind of a superstructure in the hind foot. And once again, in a patient with other comorbidities, including diabetic neuropathy, you can see at 9 weeks, we're already seeing good healing and already started some weight bearing at that time frame. And then case number 3, 56-year-old who came to me already having 3 previous surgeries, really bad cavo varus. And this is, like, as we talked about earlier, is a real challenge because basically we're trying to achieve a subtalar fusion underneath an ankle fusion, as well as fusing other joints and trying to correct this deformity. So basically you can see here on the weight-bearing CAT scan, the ankle was indeed healed. So we just removed that hardware, and you can see the deformity in the hind foot as well as the arthritis that still exists in a varus position. So we ended up basically doing a subtalar fusion with a calcaneal osteotomy. I didn't use any other screws with the osteotomy. We're able to hold all of that together with the mini nail, and then also a tailornavicular fusion. And on this lateral projection, it doesn't show it very well, but it looks like we didn't really unspin the forefoot and the transverse tarsal joint very well, but I can reassure you that we did. And if you look here on this weight-bearing CAT scan, you can see that indeed we did. And then at about 11 weeks, already had great healing and significant improvement with the deformity.
Those are great.
Awesome cases. I love that title, MIDI wins. So the
do you have it? Do you have control?
Yeah, I do have it. Yep, sure do. So fantastic cases from Josh and Terry. As a guy who has been a Nitinol lover for about 8 years, I really do believe that bones love Nitinol because Nitinol speaks the love language of bones. Bones like compression, they like stability. These devices do that for us. I'm going to show a couple of cases, and then we'll kind of wrap it up with some comments, and then again we'll end with some Q&A. So this is a guy, he's 48, diabetic, A1C is not fantastic. You know, definitely have seen worse, but he's complicate things. He's a smoker, HIV patient, prior surgery, non-compliant. It's kind of a knucklehead kind of dude. And so here's his pre-op x-rays. And at 2 weeks post-op, what I did was revised his prior surgery to a subtalar fusion. He had significant hindfoot valgus and arch collapse. So when he was standing, everything was just kind of falling apart. So, you know, instead of redoing some certain parts, I think because of his patient factors, I decided to kind of go for it. And so we did a subtalar fusion with the mini, a medial column with the mini, and supplemented that with some more Nitinol. And, you know, to Terry's point, the people who think, you know, is 1 point of fixation enough? I think, you know, for the subtalar joint and for the medial column, it's really 3 points because you have these interlock screws. You put the end cap in, so now you have a fixed angle device. So you have a lot of strength and stability here. Here's the 2 week X-ray again, just looking at the AP ankle and the axial heel, restoring the alignment. I like that axial heel is kind of cool with the subtalar bolt or the subtalar nail and the medial column nail with the hindfoot alignment view there is pretty cool. But here's at 6 weeks post-op, and as Terry was showing and Josh, you know, early healing, and so I really do give credit to the post-operative compression that all Nitinol does. So as the bone heals, as the fracture heals, as the fusion heals, whatever you're trying to get to heal, there is resorption, there is remodeling. That is the biological process. And with any other static fixation devices, the body is just kind of stuck in that phase that was placed in during surgery, which may be distracted, which may lead to a non-union. So what I love about Nitinol is it kind of gives you a little buffer and it picks up the slack and gives you that post-operative compression. So it's 6 weeks, similar to the other cases shown. You're seeing healing that you just don't see in other fixation points, especially in all these cases that have been shown are just disasters, right? You got open tibia fracture, limb salvage. You have these cases that Terry showed that are prior surgeries and, under ankle fusions. And so these are just challenging cases, and everyone showed early 6 and 8 week post-op x-rays with just really good healing. And so here's the pre-op, just to kind of put them back to back. So here's pre and post with solid fusion across, every single joint we attacked. And this is a 6 months post-op. So we have good, relatively intermediate long-term follow-up on these cases. Here's another patient, 80-year-old female, terrible flat foot, midfoot, arthritis. And she tells me her foot's been hurting for, a year or two. And this is just incredible. They show up like this. And so this patient was similarly kind of, reconstructive arthrodesis procedure to put her back together. And so just showing you some intra-op photos. So we did a medial column fusion and added some staples across her TN, first TMT and second TMT joint. And you can see here the pre and post, the pre on the left and then the pre on the bottom there, restoring her alignment. And it's amazing. This patient, her x-ray here is at 4 months. So you can see there's no question here. We have solid fusion. She wore a tennis shoe at 7 weeks. Now what's great about this is, anyone who's operated on these type of patient populations in this age group, they just cannot be non-weight bearing. It's just not physically possible for them. And so she was non-compliant from the beginning. She walked on her post-op splint. I put her in a boot at 2 weeks post-op. She walked on that. And then when I saw her at 8 weeks post-op, she was walking in a tennis shoe. Similar kind of cool case, 84. So tad older. Here's some intra-op photos. Terry was kind of talking about the steps. So you put this device in to measure what length nail you want, and then you pin it, and then you interlock it, and then you compress it with an external compression device. That gets all the maximal intraoperative compression you can get. And then you go ahead and interlock it again. And then you can see here that here is the pre-compression, right? See this yellow arrow here. And then after I've compressed it in the OR with the external device, you can see that all the intraoperative compression has now been achieved. So now all we have is the postoperative compression that's going to happen during the resorptive phase in the first 4 to 6 weeks. And that's where the Nitinol element comes in. And if you zoom in on Nitinol element, you can see that it's like, it's already pre-stretched 2 millimeters, and that thing is ready to party in the post-op phase. And here we again, another patient, 6 weeks post-op in a tennis shoe. And similar to the other cases, I mean, you just got solid fusion. And you can see the Nitinol element there on that lateral x-ray has squeezed down maybe a millimeter and a half. So that post-operative compression occurred in that first 6 weeks. And I'm convinced that didn't happen. She would have had two cannulated screws across her subtalar joint with a problem non-union in an 84-year-old who walked on it from the beginning. So I got a fever, and the only cure is more Nitinol, and anybody who knows me knows that's the way I work. And what's really cool about this is I'm a pilot as well. And so you can see here, these are the types of planes that I used to fly. So this is a Cessna 172 on the left, and this is what it looked like in the cockpit. And so that's just how I started learning to fly. So this is like equivalent to me using cannulated screws. And, so this is old school technology, and this is what I fly now. So this is a Cirrus, and you can see that the plane looks cooler and sexier, and the cockpit is way more advanced. So, when I fly, I want to be as safe as I can. And when I do surgery, I want to be as successful as I can. Just a couple aerial photos. And what's really cool is that if you crash a plane and any other type of plane, like that first plane I showed you, that's what happens, and you die. The plane that I use has a parachute on it, on the whole dang parachute. It's not like I carry one on my backpack. It's the whole chute comes out of the plane. It lands like this, and then you walk away from your plane crash, and that's the pilot right there taking a photo of the plane that went down. So again, I like to use the coolest, best things when I'm flying, and I throw these in here just to kind of show that in 2020 we have a lot of cool technology that's come out the last few years that demonstrates amazing fixation and compression. And so we'll turn it back over to Hunter.
So I just have a couple more cases show, and I mean the cases that you've seen from both Terry and Kent are phenomenal cases and are really home runs. This is pretty much a very straightforward patient, 67-year-old. Again, you'll see, as with all of our patients that we see in clinic, the vast majority are diabetics when they're getting to this point, when they have a painful flat foot. And so this is a 67-year-old diabetic with painful flat foot, failed conservative measures with bracing and physical therapy and shoe modifications. She gotten tired of her brace, and she's like, I need some type of more definitive fixation. What do you have for me? And so when we took her to the operating room, a DynaNail across the subtalar joint, and you can already see, and then also a tenonavicular fusion as well. You can already see it even at 3 weeks. The joints look great, and I think of myself as a good surgeon that takes time to do good joint preparation, but also you have to realize, like Kent was saying, when operating in 2020, if you're using instrumentation from the 60s, you're still going to have a difficult time. But when you use instrumentation from 2020s, you can obtain some really remarkable results and get early compression that looks like it's solidly fused at 3 weeks, as opposed to waiting around until 3 months to see that same type of fixation. And so now here we are 6 weeks out post-op with weight-bearing x-rays, and she looks solidly fused across the subtalar joints, and these Nitinol staples as well across the tenonavicular joint look well fused, and she's ready to go back into her regular shoes because she has minimal swelling, she has no pain, and she's off doing physical therapy. This second case, this is kind of thinking a little bit outside the box. You guys have seen some really great cases with the medial column. You've seen some great cases with the subtalar arthrodesis. This is a patient of mine, a case of mine that was sent to me after failing. He has a 26-year-old male, had a fall from a height with a peculiar, just a cuboid fracture that went into the CC joint. He is a smoker. He is diabetic. It's not the greatest of protoplasm. Had an ORAF of his cuboid back in 2015, and then had an attempted CC fusion by an outside provider, and then was referred to me for revision. And so I revised it, and I thought I was very happy with how everything looked out. My construct was 2 staples as well as a compression screw across the CC joint. 6 weeks out, the patient was doing really well, not having any pain, very happy. Then we fast forward to 4 months, and you can see the CC joint back again. So at this point, the patient's in pain. I'm frustrated. He's frustrated. And clearly, as you zoom in, the CC joint is readily apparent on the lateral x-ray, which is certainly frustrating. That's the last thing you want to see in a radiographic x-ray in a patient that's a poor healer, because you're looking at a revision. You got to figure out, okay, now that I've done plates and screws, which is what the initial surgeon had done, I've done staples and screws. My options are starting getting fairly limited of trying to not have to reinvent the wheel to try and get a fusion. So this is right after a couple months after the DynaNail came out. I'm like, well, I can get some intramedullary fixation. You don't think of the CC joint as really much of an intramedullary host, but I can get some intramedullary fixation, just change the alignment, change the axis of my compression. And I was able to get the mini DynaNail across the CC joint. You can see the CC joint is right. Oops, the CC joint's right in through there. I'll go back a second. Maybe. All right. So I was able to get compression across the CC joint and get the DynaNail in an orientation both on the axial and sagittal plane that had a good fixation and allowed me to still get the the interlocking screws both in the cuboid as well as the calcaneus. And now he's back at 6 weeks. He's still getting compression across the CC joint. He's not having any pain now, and we'll see when he comes back at it for his next follow-up in a few weeks if he's having any pain at that point. But again, just different ways to think outside the box of how we can get sustained compression, because I think that's what I was lacking. We could see how much resorption he had just across the CC joint. Now I'm hoping that with the DynaNail, I'll be able to use that 2 to 4 millimeters of additional compression because I anticipate that there will be some resorption down the road. So let's look a little bit at the surgical technique of how we put in the DynaNails. They're very similar. If you've done any type of long bone fixation with either the tibia or the femur, very similar techniques. where we put the guide wire in. You get to know exactly where you're going to be having your finished product at the end of the surgery. You put the guide wire in after you've prepared the joint. You get to put the additional guide wires in through the guide aiming jig itself to provide additional fixation so that you can move it around like Terry was talking about earlier in the program. And then what we're going to do is we're going to drill and insert the screw across the talus. Now, one thing that you will want to pay particular attention to, there are times if you do just screw fixation that you can cheat your screws a little bit more laterally. With the DynaNail, because of these threaded screws here on the lateral side of the talus, you got to make sure those will not thread into the nail. So you have to make sure that you are pretty center, and you can't allow it to be just on the lateral side. You really need to be center inside the tailor head to allow for those for that headless screw threads laterally to be completely buried within the talus, so you don't have any problems in that lateral gutter. Then you're going to apply the manual compression like Kent showed through the wire and get as much compression as you can intraoperatively. And then you're going to drill and insert the interlocking screw into the calcaneus. The nail's already preloaded with the Nitinol filament. It'll be stretched out to the maximum distraction that it can sustain. And that's all predetermined by the length of the nail, whether that's 1.8 millimeters for a 60 millimeter mini DynaNail or 4 millimeters for a 100 millimeter DynaNail. That will already be preloaded. And then as you release the nail implant, you'll start to get the compression forces of that Nitinol filament. Then you insert the end cap, and then you use closed incisions. So it's a very straightforward, easy process that will allow you to get that compression across the subtalar joint and sustain that. This is again that jig showing how you can get manual compression with that gold wheel. You'll push that up so that this metal little lip is up against the posterior border of the calcaneus. And then as you spin this gold wheel, it will manually apply additional compression. As I recall, there's about another 10 to 12 millimeters of compression that you can obtain through this. I'm never able to really maximize that entire 10 to 12 millimeters through the manual compression. Usually you get somewhere between 6 and 8. And then you will lock it with the interlocking screw, all done through the jig, all done percutaneously. So all your incisions are quite small, and you've got great fixation for your DynaNail. As far as the lateral positioning of the guide wire is concerned, you do want to kind of be in this safe zone as depicted here by the yellow lines. You want to be anterior enough so that you're going to be avoiding the fibula, but not too far anterior so that you're still within the body of the talus. That will make sure that you're avoiding, that you're perpendicular to the subtalar joint. You're in a good plane to obtain compression across and pull with the talus so that you're maximizing the compression that you're getting, as well as avoiding the articular surface of both the ankle joint as well as the subtalar joint that you're compressing against. These are some intraoperative pictures that show the guide wires of how they can be placed into the foot to help maintain your rotational stability, so that you can orient your interlocking screws a little bit more anterior to posterior, or a little bit more posterior to anterior, depending on your placement of your tailor portion of the mini DynaNail. It gives you a little bit of wiggle room, but again, you want to try and be in where those yellow markers were initially, to try and help facilitate good placement of your interlocking screws, as well as avoiding penetration of that tibio-talar joint lateral gutter.
And having that bump is really key. You got to have that so that your heel's suspended off. That's important.
Yeah, totally agree.
So what about some other additional thoughts on Nitinol? What are some other ways that we can apply Nitinol? These are a couple of cases of mine looking at some Jones fractures. We have more of a Jones type 2 on the left, a little bit more Jones 2, 3 on the right. The one on the right side was treated outside provider and surgeon for 12 weeks, non-white bearing, had a non-union evidence on CT scan. And so we thought, if we can get some dynamic compression, wouldn't that help the bone to heal up? So the one on the right again had bone grafting, and then put a little Nitinol staple across that and achieved really good fixation. I mean, the patient's as happy as a lark now because he's 6 weeks and he's walking back in his tennis shoes, whereas he spent the original first 12 weeks in a non-weight bearing his shoe. Patient on the left, same thing, Jones fracture. So I thought, okay, it worked well in the first case. Let's give it another whirl. And so I've now done three of these cases with the Jones fracture. The jury's still out, but it's certainly a different way where, like Kent was saying, it's the language of love for the bones. The bones love compression. And this is a great instrument that can provide that nitinol. The nitinol can provide excellent compression across any type of surface, whether that's a fracture or whether that's a subtalar joint or an ankle fusion. The nitinol certainly provides that type of fixation care. This is a case of Dr. Ellington's, again, looking at a fibula fracture using a 4-pronged nitinol staple that he's able to fixate the talus through the fibular fracture and then used a staple to provide that fixation, and achieved excellent compression and wonderful healing across that fibula fracture through a very small incision. And again, speaking that language of love for the fibula, for the bone, able to get great compression and healing across that fibula fracture. So with that in mind, we definitely want to thank you for joining us tonight. We do have a few questions to start to answer. So I'll go ahead and read those out. And Kent and Terry, if you want to chime in, this is a question from out west. Do you put the medial column mini through the first MTP joint plantarly or dorsal to the proximal phalanx?
This is Ken speaking. So I make probably about a 1.5 inch incision dorsal over the hallux joint, and then plantar flex the toe. And then I'm looking kind of like you would do for MP fusion or a chilectomy. And then I'm looking right at, looking end on to the first metatarsal head, and then start my procedure.
Yeah, I've done it both ways, making a dorsal incision and then also making more of a plantar incision. But I prefer what you said, just making the dorsal incision again, like you would for a chilectomy, and then you have direct exposure.
And that was been my method as well, just like I would for a hallux MP arthrodesis. Then I can just plantar flex through the MTP joints, and then I'm staring right at the first metatarsal. And that allows me to get the best orientation to make sure that I can get all the way from the first metatarsal across the midfoot and up into the talus. So
one thing I would mention about that is I had one patient that post-op ended up getting a hallux dorsiflexion MP contracture that was over time able to kind of tease down. So I've only seen it once, but you may want to just make sure you keep an eye on that big toe so it doesn't pop up on you.
And then the other thing you got to make sure you want to make sure this buried, right? Because if you will get with those long, especially with the medial column, those are going to be the 100 plus, the 100 millimeter length mini DynaNails, and so you will have 4 millimeters of compression through that nitinol. And so if you leave it right at the joint surface, you can be looking at some post-op X-rays that show the nitinol filament compressing, and then you can all of a sudden be 4 millimeters proud into the joint. So you want to make sure that you're allowing for that compression to take place while still being buried within the bone. That's the other thing to always remember, whether that's the subtalar joint or through the first MTP joint for a medial column.
Yeah, and on the guide, there's little notches that you can look at to line up what Josh is talking about when it comes to picking your appropriate length. And you do want to make sure you're definitely buried a good amount on that interop sizing, because you will, after compression, effectively the nail will lengthen as the bone shrinks. So if you're one of the things that I've heard is, man, putting in screws is so easy. Why do I want to do this? And so we did a little kind of anecdotal study in the OR recently, where we timed how long it took to put 2 screws in, and we timed how long it took to put the mini DynaNail in. And the mini DynaNail is actually a little faster, even though it has more steps. So, and it can get, if someone who's not done it, I don't want them to think that this is a complicated procedure. You do a normal procedure, normal joint prep like you normally would. Then you put the sizing, you put the guide in, you put your interlock, you compress it, you put your other interlock, and you're done. So it seems sometimes a little bit like, oh my gosh, there's a lot of stuff to do, and there's 10 extra steps, and there really isn't. It's just a couple extra steps, and the time it takes you to do those couple extra steps will be the time you would have, fiddled putting in another screw.
Yeah, I mean, it's not a steep learning curve. Once you've done a couple, then you'll feel like it's just as quick as putting in screws.
Agreed. Ken, Terry, have you guys had any issues with the cost of the DynaNail or the mini DynaNail as opposed to the surgeon that put down the hallway that's doing the same surgery but only putting 2 screws in? Has that been an obstacle for you guys to overcome at all?
I mean, certainly you got to think about surgery centers and costs like that, but I think the other thing to think about with cost is, if you have a failure. I mean, what happens if you don't get a union, and then you have to come back again, and which thing is in your hands is going to make it less likely for that to happen. So I think it's not just the cost of the first surgery, but it's, if you have something that you think potentially is going to avoid complications, then you're taking away that other potential cost in some cases.
Yeah, I would echo that. Specifically in the surgery centers, you do have to be sensitive to those issues. Luckily, where I am in Charlotte, certain insurance providers will pay for implants for surgery centers. So in those situations, luckily, it's a non-issue. A lot of these cases that are complex are being done at the hospital where the mini DynaNail is already approved. And, just the way the system works, kind of doesn't matter to some degree what happens there when it comes to the patient burden. And then, I think Terry and Josh would agree. I don't know if every subtalar fusion needs a mini DynaNail. My opinion is every medial column needs a mini DynaNail. I think that is the superior fixation strategy. When it comes to subtalar joints, I mean, I still do screws occasionally. Every time I do it, I kind of feel bad because I'm so committed to the Nitinol story. But it's just not practical all the time. And so I think you do got to pick and choose your battles, and we're not trying to say that every single case is a mini DynaNail case, as much as I'm sure MedShape would like, but you have to be a little reasonable when it comes to these things.
Yeah, totally agreed.
Yeah, I agree. Originally the DynaNail for the TTC fusion was my revision backup nail, but when I started having such good results and success and outcomes with it, despite being used in revision cases and with patients that have had a history of non-unions, as I've transitioned more to that being my primary nail, as well as within the subtalar joint, I've been so pleased and so happy with the outcomes. And not having any type of non-unions there, and knock on wood so far, that it's, I'm starting to rethink my process though, of making this more of a primary thing as opposed to just a revision for that reason alone, because I'm not having to go back to the OR to revise a subtalar because the screw, or take out hardware because the screw heads are too prominent, or because there's some resorption across the subtalar joint. This has really alleviated a lot of those fears for me. But I would agree, for a medial column, definitely the way to go.
It's interesting. The cost of a non-union has been reported anywhere from $50,000 to $80,000. So to Terry's point, if you have a non-union and you're going to now that's going to be a $60,000, $70,000 surgery, an extra whatever it is, $1,000 for the mini DynaNail is honestly pennies. So, 2 cannulated screws, headless compression screws, aren't cheap as you think. So something to think about.
For sure.
So this next question is about that interlocking screw into the talus. Have you ever had to drill through the fibula to put it into the subtalar joint DynaNail, or with the Charcot and a medial column fusion? Have you guys ever run into that issue of having to deal with the fibula being in the way?
Yeah, I mean, the big thing is you just got to think about where you're placing everything ahead of time, and just know that, you know, if you're going to do the mini and the subtalar joint, you're also going to have a medial column. You just got to plan and make sure you give yourself enough for real estate, but still try to stay into that safe zone, because, you know, you can't put it through the fibula. That's just not an option.
Yeah, I agree. It's just real estate management. Somebody had a question. If they're still on, I know they want to hear my answer to the comparison of a Cirrus and a 172 and the mini and screws. You know, simply the Cirrus has air condition, and that's good enough for me right there. And then we talked about the benefits of the mini over the
Yeah, there's another good question there that I think went off that I get a lot is how, you know, that someone had asked if, you know, what happens if you don't want to overly compress. So I get that question a fair amount from people about, you know, are you worried about over compressing, you know, in some situations?
Yeah, luckily I haven't seen that. You know, when the DynaNail first came out, and I have the same story as Josh. I used it for revisions for a year or two, and now it's the only nail that I use. I haven't done anything besides a DynaNail for a TTC in 7 years, and that was a big thing. People, oh my gosh, you're going to squeeze the bone, you're going to kill the bone, you're going to too much compression, you're going to shorten their leg. I mean, I've done over 50 now, and I've reported on a series of over 30. And it doesn't happen, you know. So there's a great two questions here. One, has anyone done a subtalar fusion using the mini nail under a total ankle? And we recently just learned of this. We had a guy who did this out in California, good friend, excellent surgeon, who just shared his x-rays, and it looked fantastic. And I tell you, if there's a great indication, that's one right there. Like Terry was talking about real estate management, and his x-rays he shared with us showed a solid arthrodesis early on under a total ankle. So I think that's a great you know, indication for this technology.
Yeah, I would agree with that. I've only had to do it one time, but that patient's only about 4 months out, so I don't have the 6-month x-rays to show or anything like that. But I agree that that helped to simplify nice, easy compression without having to get the two screws too close to the talar implant to worry about pushing that off at all, and able to obtain some really nice compression across that.
I haven't done it yet, but wouldn't shy away from it.
There's a question about joint distraction across the custom cage with a mini DynaNail. And I actually just saw a patient in clinic last week that I'm going to do this. So I'm going to use a company called Restored 3D that is based in Durham. Some of the people who are behind MedShape started this company, and I'm going to have them print me a custom cage and plan it to where I can put a mini DynaNail through it. The patient had a calcaneus fracture 5 months ago, treated non-operatively, no insurance, non-English speaking. Unfortunately, he got hurt at work and doesn't have workman's comp insurance. So we're working through all that. And because of his calcaneus, he just showed up to me this last week. He's, again, 5 months old. His talus, he had a Sanders 4. His talus is halfway in the middle of his calcaneus. He's already has anterior ankle impingement. So we're going to do a custom cage to distract his subtalar joint to restore his hind foot height, and then pack that with every biological thing I can think of, and put a mini nail, you know, through the custom cage through the subtalar joint. So that'll be coming up in a few weeks.
Then one last question: any tips for doing distraction arthrodesis with the custom cage and the mini DynaNail? You thought about? Is that what you're trying to talk? Is that what you're talking about, Kent?
Yeah, that's the one I'm going to do. You paying attention?
I was responding. I was typing into another question. That's my story. All right. Are there any other questions out there? Feel free to submit them. We'll wait just one more minute to see if there are any additional questions. But like Kent and Terry have been saying, I mean, I am definitely drinking from the Kool-Aid when it comes to Nitinol. I think it's Kent's the one that turned this on to me with during my fellowship training, and really the amazing properties and the characteristics that Nitinol possesses. We all know that bones love compression in order to heal. And so why not use something that will continue to compress underneath any type of joint, or who knows, across fractures, or whether that's a Jones fracture, fibular fracture, midfoot, Lisfranc's. I mean, I think there's lots of different interesting and intriguing uses for Nitinol in the future. It'll be interesting to see what continues to come out and how this continues to evolve going forward. Any last thoughts, Kent and Terry?
Thank you, guys.
Yeah, I really appreciate you guys jumping on with us, and hope you guys have a wonderful night and stay safe, stay healthy.